Dr. Julian Huppert, Mental Health and the Cambridgeshire Health Economy. Dr. Huppert.
Thank you very much, Dr. McRae. It's a pleasure to serve under your chairmanship, and I'm delighted to have secured this debate on a key issue for my constituents, which is healthcare and in particular mental health. And our NHS is something to be proud of, the brainchild of the great liberal beverage brought into being by the pioneering Labour government after the Second World War. It is an amazing institution, providing care for all of us, free at the point of use. And I pay tribute to the excellent work of NHS staff who work tirelessly. And incidentally, I hope the government will ensure they're paid appropriately, because independent pay recommendations should be honoured. But our NHS is not perfect. It is under strain. And if you look back at the debates when it was established, Dr. McRae, you'll see it was predicted to run cheaper every year as people became increasingly healthy. And that's the opposite of what has in fact happened. People live longer because we're learning to treat more and more conditions, but that costs us more and more. Demand grows rapidly, the range of things we can do increases, NHS inflation outstrips standard inflation, leading to huge cost pressures. Now, much of the solution lies in preventative measures because it's of course cheaper to keep someone healthy than to treat them when they're not, but there's never enough money on this as it's so often needed for treatment. And some areas are shamefully neglected. And mental health in particular has always been left behind. Now, a lot of this is a product of historical, outdated social attitudes, questions about shame, about how people ought to be, about what was normal. And indeed, many people used to believe that mental health problems were a deficiency of character. Now, this is, of course, rubbish, and I don't think anybody in this House would share that view today. But there is still a stigma attached to mental health conditions that simply should not be there. People aren't prepared to talk about it, to admit problems, to seek help. And as well as anguish for many people and their families, this materialises in discriminatory policies. For example, when the last government introduced waiting times in our NHS, arguing perfectly reasonably that this would improve provision for somebody with cancer so they wouldn't have to be kept waiting for treatment, they did not include mental health. It was taken almost for granted that mental health delays were less important than physical health ones. And of course, bodies charged with funding reacted. They pulled more money away from mental health in order to hit the new targets in physical health. An understandable reaction. And I'm very glad that that policy era is now over, that we have now legislated for parity of esteem between physical and mental health. And thanks to the excellent work of my right honourable friend, the Minister, the member for North Norfolk, we're introducing the first ever waiting time standards for mental health next year, described by charities as a watershed moment and far too late in coming. And there are other improvements. The recent £150 million tackle eating disorders, for example. But we have to go much, much further. Because people are suffering now and simply cannot wait. And on Saturday, I was at the wonderful Mill Road Winter Fair. We had a Lib Dem stall there. We were asking people to come and talk to us about mental health, get some information and sign a petition supporting our call for an extra £500 million for mental health, which I do reiterate today. Huge numbers wanted to sign. It's an issue many people care about. And we raised lots of money for Centre 33, which helps provide free and confidential counselling and support for young people, and heard some astonishing tales. And let me just paraphrase one of the stories of one of the people who came by. A woman who had been suicidal for a year, had no fixed address. Went to see a GP who asked her to come back regularly to check that she was okay. She went for a bit, but then stopped going, and strangely this triggered no alarm bells that a suicidal patient who was being monitored had stopped showing up. She went to another GP and was told she'd be referred to the community mental health team, but nothing happened. Third GP sometime later suggested referral, but found nothing on her notes to suggest she ever had been referred. 3 months after seeing the first GP, she was finally given an appointment to see a psychiatrist 5 months later. That happened. She was put on the waiting list for therapy, an 18-month waiting list, which she's still on. In the meantime, she's lost her job and is in an extremely difficult situation. No wonder she and many others say we need a change. And this isn't new. 8 years ago, my predecessor David Howarth spoke out against £3 million of cuts to mental health services in Cambridgeshire that led to the suicide of Julie de Lochry. And there are many stories across the country and across the decades. And I heard more stories when I worked with service users at LifeWorks, a mental health drop-in centre in Cambridge which was threatened with closure. Now, I'm delighted that closure has been stopped, and proud I was able to help in that, talking to users, the Mental Health Trust, raising the issue in Parliament. But I'm far prouder of the work that was done by the service users themselves and their friends. And in particular, I pay tribute to Anne Robinson for her efforts. Too often things are done to people with mental health issues rather than with them. And the now reversed decision on LifeWorks was partly the result of funding problems. So let me focus on the funding situation in Cambridgeshire, one of the most troubled health economies in the county. We are very underfunded. In 2013-14, our CCG got the second lowest funding per head in the entire country, which has improved slightly since, but we are still far below where we should be. Now, somewhere has to be second lowest. This is not a fair share. The government has a fair share formula, and as that's been revised to quite correctly take account of deprivation, we are £35 million below the fair amount of funding that's been calculated. £961 per head in Cambridgeshire and Peterborough, whereas in West Norfolk, just next door, £1,255 per head. Now, we are getting a slightly larger increase than others, 2.9% rather than 2.14%, but at that rate it'll take about a decade to catch up, with no compensation for the years of underfunding. Now, I accept that NHS England make those decisions about how we get to the fair rate, but I hope the Minister will agree that the pace of change is simply too slow. We have other problems. Our population is growing fast. Cambridgeshire is growing the fastest in the country, and Peterborough is the fastest growing city. That's an even greater strain on funds, because a population increase is not properly taken account of. So despite our funding per head going up slower than the national average, we still have that despite being very low to start with. Can the Minister ensure that growth is no longer penalised? And we have the legacy of poor decisions. 2 massive PFI projects under the last government at Hinchingbrook Hospital and to Peterborough Hospitals, the biggest and perhaps the worst in the country, sucking money out of our system. And I was shocked preparing for this to find the PFI repayments on Peterborough represent a staggering 18% of the hospital's budget. So we start off with less money than elsewhere, have more of that taken away before we even start. And we have other legacy issues. Cambridgeshire has repeatedly been used as a test bed for experimentation, such as the £1 billion privatisation of Hinchingbrook Hospital, led by the last government under their legislation. They put it out to tender, had not a single NHS bid in the final 5 bidders. Addenbrooke's Hospital pulled out because the cost was too large, and left a list of 3 private bidders for this government to choose from. Not a great choice for this government to have to make. But it's why I find it frustrating the Shadow Health Secretary claims to have clean hands on what happened with Hinchingbrook. He's been claiming that one of those 3 was an NHS provider. He did so in the House today. And I've been trying to find out which one of Circle, Ramsay and Serco he considers to be part of the NHS. And he's answered in a Twitter today. He said that it was the one which was Serco, which was associated with an NHS body. Dr. McRae, the day that Serco counts as an NHS bidder is a day I hope we will never see happening. And there are still problems at that hospital. I'm pleased, by the way, that the recent tendering for the Cambridgeshire Older People Services, which I'll talk about later, under the current government's legislation, which incidentally I oppose, I don't think it was right when this government did it or the last one, but under this legislation, that bid went to the NHS, the Mental Health Trust and Addenbrooke's Hospital, providing better services. So we start off with a historic position and low money. So no wonder we struggle to fund mental health properly. But it gets worse because the Clinical Commissioning Group ran a small deficit last year, hardly surprising, and so it's ineligible for quality premium payments, which could bring in another £1 million. How can it make sense to starve funding from CCGs as a punishment for not having enough money to do the job properly? And I'm sure no one will be surprised that there is a correlation between budget outcomes and how well funded CCGs are. Areas with funding above their fair share calculations run surpluses, and those funded below their fair share run deficits and get punished for it. And this year, the deficit, the 4.9 million, compared to an underfunding level almost 10 times that, has to be repaid, put even greater strain. And so we come to mental health funding, and in fairness to the CCG, it provides about the same allocation to mental health proportionately as everywhere else. Just that we start off with far too little, so they get far too little, one of the worst funded in the whole country. Despite the fact that we've seen underinvestment for a very long time, huge pressures, growing demand, 12% increase for people with serious and enduring mental illness, but no money to cope with it. And again, because when the last government introduced payment by results tariff systems in physical health, but left mental health using the block funding system, extra demand, extra work doesn't lead to extra funding. Yet again, changes made to help physical health rather than mental health. And as we quite rightly reduce stigma, as we tackle the huge unmet need for mental health support, more and more people realise they need help, seek it, and discover that it isn't there for them in the way that they need. And we've seen other problems. The suggestions from NHS England about differential deflators, larger savings on mental health treatments, on physical health treatments. And I know this infuriated my right honourable friend, the Minister, and I understand it won't be repeated, which is welcome. And I was disappointed my own clinical commissioning group complied with that, although they did, in fairness, give an extra £1.5 million for mental health services, and as of next April give a further £2.2 million to help targets for access to IAPT. Now, Dr. McRae, the Nobel laureate Ernst Rutherford said, "We haven't got any money, so we'll have to think." And of course, providers in Cambridgeshire and Peterborough have had to be creative to cope with the awful funding position. So we have seen many innovations. Mental Health Trust has set up a single point of access known as ARC, reduced out-of-area placements, focused more on community teams. And the Recovery College is doing some very, very good work advancing the recovery model of mental health care. And I think we're doing some amazing things about using more efficient resources for joint working. So the £800 million for Cambridgeshire Older People Service, which, as I said, stayed within the NHS, will combine acute trusts, mental health and community care to help people seamlessly, so people are not passed between one organisation and another. And in particular, it should mean a sharp decline in the number of delayed transfers of care, where an older person is stuck in an acute hospital bed at great expense, not to their benefit, because there's no alternative available in the system. No longer will Addenbrooke's Hospital have to negotiate desperately for community care beds. It will be one system. And because of the contract design, with outcomes-based contracting, there is an incentive to reduce the need for treatment rather than rewarding activity, because keeping somebody healthy longer is better for them and cheaper for us than treating them when they're ill. We have to do much more about prevention. I know the Minister who is here today cares very much about that. And Simon Stevens, in his 5-year forward view, called for a radical emphasis on public health and prevention. And promoting public mental health must surely be a key part of this, with resilience and well-being core. And I know that Mind recently called for local authorities to prepare public mental health strategies, and indeed in Cambridgeshire the County Council's Health Committee, chaired by the excellent Councillor Killian Burke, already commissioned such a strategy, planning to spend £120,000 on it. It will attempt not to promote just mental health in the very widest sense, but to target those groups that are particularly susceptible to experiencing problems and investing in evidence-based interventions that will have an effect. And we also need to focus on recovery. And the Mental Health Trust Recovery College is leading the way in that. Recovery is an approach to mental health that recognises that full recovery is not always possible, some conditions are lifelong, but seeks to enable patients to recover their lives from their conditions so they can live more fulfilled lives, rather than the attachment model with people stuck as service users forever and ever. But of course, it has to be properly resourced, not simply used as an excuse to close services down. Otherwise, discharged patients will simply be shut out of services and return to being bounced around the system looking for crisis care. We do need good crisis care as well, so people can have help. And again, I pay tribute to my right honourable friend, the Minister, for his work on the Crisis Care Concordat, to bring organisations together to deal with these crises. Currently, there is a huge load on the police and acute hospitals dealing with people who shouldn't be there but have nowhere to go. And we have to make sure there is a wider understanding of mental health throughout the health system. Primary care is key here. And I am astonished, Dr. McRae, that GPs do not have compulsory training in mental health. It is surely one of the things they will experience on a very, very regular basis, given that 1 of 4 of us will have a serious mental health condition at some point. Why are GPs not expert in this area? They could do far more to help people to remain independent, become recovered, and to live better lives. And the voluntary sector is also key, and I pay particular tribute to organisations such as Mind in Cambridgeshire, with their very able Chief Executive Sarah Hughes, who's driven forward the Crisis Care Concordat, which was signed for Cambridgeshire and Peterborough just a couple of weeks ago. But also many organisations, Rethink Mental Illness, the Richmond Fellowship, Lifecraft, Centre 33, Pinpoint, the Sun Network, Arts and Minds, and many more. Their work is hugely valued. And finally, Dr. McRae, I want to focus on an issue particularly close to my heart, that of child and adolescent mental health. And this is very important because children who experience first mental health problems at that stage can often be helped and completely recover. It's often a product of their environment, and early intervention can be radically preventative, but waiting lists are far too long. And again, in Cambridgeshire, the Health Committee is trying to work with Centre 33 to provide more counselling support for young people. We have to go further with that. Something we have to sort out. And I've been contacted by Pinpoint and Healthwatch recently about the urgent need to do more for CAMS, and indeed many of my constituents have been in touch as well. Dr. McRae, there is far more that I could talk about in this context. I could talk about the troubled implementation of the EPIC e-hospital system in Addenbrooke, so the lessons that we have to learn from that, the ongoing problems we have for the East of England Ambulance Service, the desperate need to reopen community care beds in Brookfields Hospital so that people can be moved out of Addenbrooke's into appropriate care. And I could talk about many positive things, such as the move of Papworth Hospital to the Cambridge Biomedical Campus, which is now proceeding apace. Planning permission recently granted after my right honourable friend, the Chief Secretary, approved the funding. But let me conclude instead with a plea. Mental health services in Cambridgeshire and across the country are simply not good enough. I welcome the commitment of the government to change this, parity of esteem in particular, but this is not enough. We also need more money in mental health care across the board. Hence my plea to the Minister for an extra £500 million targeted at mental health care. And for Cambridgeshire, we face a financial crisis across all forms of healthcare. Our low funding levels, historic commitments and growing population create a triple whammy. But there is a way forwards. And just yesterday, I took the Chief Executive of the Mental Health Trust and the Chair of the Clinical Commissioning Group to see my right honourable friend, the Minister, to make the case, and I think he was sympathetic to our position. And let me say here, and to this Minister, what I said there and to that Minister. There is an opportunity with the extra money that I and others campaigned for in the autumn statement. The extra £2 billion will have to be allocated somehow. What formula should be used? I would urge the Minister, in the strongest terms, that the current ratios should not be used. That would mean giving extra money to those areas that are already getting more than their calculated fair share and less to those of us who are behind the fair share. Instead, and I hope the Minister will press NHS England to this, it should be used to jumpstart the shift to the new fair formula. I understand why transition is being done slowly. Those areas with more funding than the fair share probably don't feel overfunded, even though they are more able to run surpluses. This new money allows us to correct the deficiencies for low-funded areas without creating losers. I'm aware that £200 million of it has already been earmarked for challenged health economies, and we are one of the 11 that have been so labelled. And while I welcome this, the government should allocate all of the money to move people up to their fair shares where they're below. And I know that if our clinical commissioning group got the missing money, the £35 million the fair share formula says we should already have, plus our share of the extra £2 billion, a high proportion of that can and would go on mental health care, transforming, helping and saving many lives. I hope the Minister will do what she can to make sure that that happens.
Call the Minister to respond.
Well, thank you very much, Dr McRae. Pleasure to serve under your chairmanship. And can I congratulate the Honourable Member for Cambridge on securing this debate and commend his ongoing interest in local health matters. I know from meeting only yesterday with the chair of his CCG that he is a consistent champion for local services. And I'm sorry that my right honourable friend, the member for North Norfolk, can't be here to respond to this debate, but he's already shown a keen interest in the subject of our debate, and I know will take action forward. I'd also like to echo the proposing members' tributes to NHS staff, which he quite rightly made at the beginning of his remarks. And of course, Dr McRae, we'd all agree that good quality patient care has to be expected regardless of where in the country we live. Mental health services were, quite rightly, as he said quite rightly, for too long the forgotten area of the health service. But it is changing under this government, and we'll touch a little bit more on that later. But we say at the outset there is, however, much to do. I think we all acknowledge that. I also welcome, although we won't dwell on it too much in this debate, but I think he's actually right to include in his remarks comments around prevention and around building resilience. Clearly, as the Public Health Minister, issues around prevention are very close to my heart. But I think it's also right to talk in those broader terms about building resilience in individuals, and that's an area which I know considerable thought is being given to in terms of making it possible for people to withstand more of what life throws at them, particularly around young people. Just moving on to questions of national funding. For 2014-15, NHS England allocated £64 billion to CCGs for hospital, community and mental health services. That was an increase of 2.54% or £1.59 billion on the previous year. Now, in making their allocations, NHS England relies on advice from one of our many health acronyms, ACRA, the Advisory Committee on Resource Allocation. And ACRA provides advice on the share of available resources provided to each CCG in order to support equal access for equal need. And I recognise that much of our debate might revolve around those funding formulas and how they are evolving. The calculation is based on the age of populations, relative morbidity and unavoidable variation in cost. The objective is to ensure a consistent supply of health services across the country. The greater the health need, the more money is received because the more health services are needed. The CCG model obviously covers only non-specialised hospital and community care plus primary care prescribing. Now, I understand that the baseline can and does vary systematically between locations, and that to some extent reflects different historical commissioning priorities in the predecessor organisations, the PCTs, or a different mix between the local and the area commissioning responsibilities. NHS England, however, did review the funding formula for 2014-15 and following years, and they now use an approach known as person-based resource allocation, PBRA, which was developed by the Nuffield Trust. Now, compared to previous target models, this allows information about individuals such as age, gender, recent hospital diagnostic history to be combined with information about the area they live in, which, as the Honourable Member will know, is frequently linked to deprivation. The PBRA formula estimates the relative need of each individual, and then at CCG level, the estimates are then the most accurate ever used for allocations. So that is obviously a change in terms of how that's done. Pace of change is often the issue for these debates. In relation to that pace of change, from the actual allocation towards the target allocation, the option that NHS England agreed for CCGs reflected the challenge of directing additional funding to those CCGs that are the most under target, as my friend was outlining, whilst not at the same time destabilising those areas whose allocations are above target. And certainly in previous debates I've seen this very much in London, and obviously if people have had a particular allocation for a very long time, one has to be very mindful that people are planning for that, and therefore these things have to be done in a sensible way. That obviously continues the policy of maximising growth for those furthest below target, and we do appreciate that CCGs in the east of England are further below their target allocations than in many other parts of the country. It's right to draw attention to that, and that Cambridgeshire is one of the furthest behind target by some £45 million, 4.85%. Now, the NHS England is already spending £500 million over 14-15 and 15-16 to bring under-target CCGs, such as Cambridgeshire, towards their target allocations. And that approach was discussed and decided at a public board meeting nearly a year ago in December 2013. But I recognise he's also pushing us to where this goes for the future. And he'll be aware that following the autumn statement, the announcement by my right honourable friend, the Chancellor of the Exchequer, of a further £2 billion for frontline services, NHS England is currently reviewing those 15-16 allocations. I hope that NHS England share his hopes that they will consider how some of that extra £2 billion could be used to help some of those furthest behind, including Cambridgeshire, to get closer to their fair share. I know it is, as he said, something he's already discussed with my right honourable friend, the member for North Norfolk, who takes it extremely seriously, and that my right honourable friend is committed to raising the matter with NHS England prior to them making a decision at their board meeting, which this year is on the 17th of December. Just turning to mental health services in his local NHS, I do want to, as he very much drew out in his remarks, start by recognising the commitment and the dedication of the staff who provide mental health services, whether that's people working in specialist trusts and settings, but also those working in primary care who might be providing services on a daily basis. And he also, I was pleased to see, drew out that large army of people absolutely critical in mental health, who are often not formally part of the NHS composition of services, but are invaluable to it and supporting it. Those are the carers and the volunteers, sometimes working through charities or voluntary organisations. He referred to Centre 33 and a number of other organisations in his area. Sometimes it's simply an individual helping or caring for a parent, a friend or a neighbour because they think it's the right thing to do. Without those people, the job of the health services would be immeasurably more difficult. And so I pay tribute to them as he did. Very briefly, yes.
I'm grateful to my friend for giving way. On that specific point, will she praise the West Essex Mind, which have their annual general meeting this Friday, that do so much to help mental health services in Harlow and across Essex, and are the exact example of a charity working deeply rooted in our community?
Of course, I join him in those tributes. It's quite obvious from the comments of many honourable members in this House that their local branches of Mind and other groups do terrific work, and he clearly has a good relationship with those, and has taken the opportunity to place his regard for them on the record. Now, just with regard to the Cambridgeshire health economy, this government has increased funding for mental health by £120 million in 2014-15, which brings total mental health spending in England. It will rise from £8.5 billion in 13-14 to £8.62 in 14-15. And obviously, Department of Health and NHS England continue to work together and on this important topic. But I do recognise the challenge faced by the Cambridgeshire and Peterborough health economy. I have to say I agree with him about the PFI decisions made by the previous government about Peterborough and the problems that they have left, the legacy of problems that they have left. But action is being taken on that, as he knows, and work is going on between NHS England, the NHS, TDA and Monitor on a programme to support 11 of the most challenged health economies, of which his is one, to address those with long-term integrated plans. The programme's now been put in place in Cambridgeshire, jointly funded by all local NHS partners and underpinned by a concordat on joint working. And the purpose of that is to find a collectively agreed solution to closing the financial gap facing the economy as a whole, while still obviously improving care for his constituents and all those others served by the local health economy. And that work is due to identify proposals by the end of June 2015. Mental health is an important part of that, and emerging ideas focus around closer integration of physical and mental health and an expanded role for mental health input to a range of hospital settings and community pathways, such as those for long-term conditions. I know only too well as Public Health Minister that you very often have these extreme comorbidities, and we often have to really look at the person in the round and all the things that are interacting in terms of their personal health care. I know there will be concerns that mental health services could be disproportionately affected. We don't think that would be acceptable, and whilst payment for mental health services is agreed locally, we would expect that local commissioners and providers have regard to national tariff arrangements, although they can obviously be flexible where there's good reason to be so. The tariff arrangements for 15-16 give a very clear signal to the mental health sector to move away from simple block contracts, which currently apply in Cambridgeshire, and are not transparent, to local payment models which support recovery and outcomes, as he highlighted in his remarks, and reflect the needs of local communities. Cambridgeshire and Peterborough CCG actually invested an additional 1.5 million, he's right to pick that up, to address those capacity pressures. So we can see that there is a real commitment there, I think, from his CCG, and clearly he is going to continue to champion that. They're also committed to investing a further 2.2 million from next April in delivery of IAPT. He is right to pay tribute, I think, to my ministerial colleague, the Right Honourable Member for North Norfolk, who has championed in this Parliament mental health policy very effectively. He drew attention in his own speech, Dr McRae, to this government's commitment to parity of esteem, made explicit in legislation. We can also point to the 2.4 million people who've entered treatment under the IAPT programme, and over 1.4 million who have completed that treatment. £54 million invested over the period 2011, 2015, 16 in the Children and Young People's IAPT programme. And he is right to say that children's and adolescent mental health services are a critical part of our local care pathways. And for the first time ever, the Mental Health Crisis Care Concordat, signed by over 20 national organisations to improve the system. He was right to draw that out, and as he says, Cambridgeshire already has one, has got that in place. £25 million to enable vulnerable offenders to be identified when they first enter the criminal justice system, and the aim is for 100% coverage by 2017. So there's a lot going on. I think we all acknowledge there is a great way to go in terms of mental health, but I think it's right to say that there is those are important milestones along the journey. I know that the NHS nationally and in his local area are working hard on these issues and some of the wider funding issues. I hope I've given him some assurance that progress is being made. As I said, he's already had a commitment from my right honourable friend, but I will reiterate that when I return to the department, that we want to make representations about the points he's made in this debate to NHS England ahead of that critical funding meeting, and I obviously encourage him to keep closely in touch with his local NHS, which I can see that he does. So I thank him for bringing this debate, and I hope that gives him some measure of comfort that there is considerable progress underway on this important agenda.